Alright, so it's been a very long time since I've been able to come back and do this, so I want to finish up this playlist real quick. There's not much left. In Respiratory, we're up to the last few videos, and then that'll be done. So let's just delve into it while we're waiting for a couple more people to join. The only thing right now is after finishing this playlist, anyone that's preparing for step 1, they should go into those live Amboss QBank videos I have. Obviously do a bunch of NBMEs. I have videos for some NBMEs. I'm currently working on the NBME 24 explanations. Those are things you should look into. Do your own NBMEs and then come back and check the revision, check, how to come at the right answer choice, stuff like that. And just keep practicing, right? And then if Prometric doesn't cancel your test, of course, you get lucky, you go sit in, take your test, get that done with. Last time, which was quite a while ago, the respiratory video number 18, we were just looking at more questions after we just finished talking about the various types of pneumothoraxes. Right, so this entire playlist, the mastery playlist, is all about gaining a mastery of topics, and this would be one topic, right? So pneumothoraxes, and having a mastery of this topic would mean that you could sit there and write down PSP, SSP, TP, and tension pneumothorax, and just be able to talk about the differences of these pneumothoraxes without looking at the book. And then further be able to explain how questions might present, what the x-rays and other findings might look like, stuff like that, right? Because that's what's going to be in your exam. You're going to get scenarios, and we did a bunch. We did a couple scenarios. We also picked on key words of different types of pneumothoraxes. Like if your question mentions apical subpleural blebs or cysts, you know it's a primary spontaneous pneumothorax, which is usually going to be a very skinny, almost anorexic looking young white guy, right? So something like that is what's often going to show up in questions. We've also finished talking about pleural effusions in the last video and the time before that, where effusions were a big deal, right? So the difference between an exudative and a transudative effusion. That would be another topic for you to gain mastery on, and you should be able to explain it without the book in front of you. It's really, really important to be able to do all of that while you're studying before you move on to the next thing. So right now, there's just a couple more UWorld questions to look at. I have a UWorld and Amboss questions to look at on this page. More x-rays, and then we'll dive into pneumonia, which is a huge high-yield topic for respiratory on step 1. So let's just go right into it. Amboss is the first question I have here, and like Fadi here is saying, Amboss and UWorld are very similar, extremely similar. QBanks, both of them. Now, the reason you don't want to do just UWorld and you want to go ahead and explore Amboss too is because you want to be able to have multiple views of the same question. Same topic can be asked about in so many different ways, and it really helps to be able to see the different ways things can present. Sometimes UWorld will piss you off because an answer choice might be so vaguely worded that even though you knew exactly what was happening, you couldn't do it. And sometimes Amboss is going to piss you off, but that's all part of learning, right? You see things being presented in such an obscure, weird way, and then you get to create that mental network that weird presentation was actually relevant to your topic. So here, the first question we have: 8 hours after undergoing successful cholecystectomy, a 65-year-old man with scoliosis complains of shortness of breath. So this first sentence alone gave away a lot here, right? So he had to get a cholecystectomy. That tells you a lot about his well-being. He's 65, so he's definitely elderly, and he has scoliosis, which tells you that the skeletal framework he has isn't exactly optimal or ideal. So shortness of breath is definitely relevant to the skeletal framework with your ribs and your spine. Respirations are 28 per minute, and pulse oximetry on room air shows an oxygen saturation of 85%. So the 28 per minute is pretty high. Normally, respiration 28 per minute, you don't need that. 20 is a good maximum. If anything, no one should be breathing at 28 per minute on rest. And then, of course, the oxygen saturation is very low here. There's no reason for it to ever be below 90% if someone is healthy. Physical exam shows kyphotic deformation of the thorax. So again, very clearly, because of his kyphoscoliosis and whatnot, he has some kind of deformation in his skeletal setup. Cardiopulmonary examination shows intercostal retractions and diminished breath sounds on the left side. There is trace pedal edema bilaterally, right? Trace pedal edema bilaterally. An X-ray of the chest shows bilateral fluffy infiltrates, and the cardiac silhouette is shifted slightly to the left side. Which of the following is the most likely explanation for this patient's hypoxia? Right, and they had a bunch of answer choices that would all kind of look plausible, or at least more than just one answer choice would look plausible, but you want to figure out what's most likely to explain the hypoxia, right? So the answer for this question was collapsed alveoli. What's happening here? So dyspnea, hypoxemia, diminished breath sounds, and mediastinal shift toward the affected side in this post-operative patient are all suggestive of lung volume loss. Right, so one key word here is this hypoxemia, right, which is they're using that instead of hypoxia because it's actually his oxygen saturation that's low, not the fact that he's not getting enough air into his body. And the mediastinal shift, which they talked about, the cardiac silhouette being shifted to the left side, was also really significant for figuring out the diagnosis here. This patient's symptoms and X-ray findings are suggestive of Atelectasis, which is one of the most common postoperative complications and results from the collapsing of alveoli. This patient's decreased breath sounds on the left side and a slight mediastinal shift to the left are consistent with Atelectasis that is worse on the left side. Right. So remember we talked about tension pneumothorax. It means that you try to go away from tension, and that's the one time that the shift is on the opposite side. But this guy is having diminished breath sounds on the left side and cardiac is shifted towards the left side, so that's atelectasis. That lung has practically collapsed. Risk factors for atelectasis include immobility, recent surgery, and conditions that reduce aeration to the lungs, which this patient has all three of, right? He has the kyphosis, scoliosis issue. He has the immobility. He's 65. I'm pretty sure he's not running marathons every day. And he just had recent surgery, which also further amplifies the immobility. You definitely don't do much right after a surgery. Next one. 2-year-old boy is brought to the physician because of coughing and difficulty breathing that started shortly after his mother found him in the living room. Okay. Living room, playing with his older brother's toys. He appears anxious, respirations at 33 per minute, which is again high. Pulse oximetry is 88%, which is low. Physical exam shows nasal flaring and intercostal retractions. Auscultation of the lungs shows a high-pitched inspiratory wheeze and absent breath sounds on the right side. No improvement in his oxygen saturation after applying a non-rebreather mask with 100% fractional intake of oxygen. Which of the following terms best describes the most likely underlying mechanism of the right lung's impaired ventilation? Now, this is a really big topic. This right to left shunt thing is something that a lot of students tend to often not quite grasp, right? So it's a topic that's pretty rarely spoken of, and it's not really described much in first aid either, but they do talk about it. So let me scroll back up to one of the important pages where they talk about all of these various little differences. Let me see. So many practice questions in this chapter. It's one of the best reasons to have this first aid on hand. With all the practice questions and extra notes in here, you really end up mastering respiratory quite well. Oh, this is the pathology section. Okay, hold on. So they talk about the right to left shunt and stuff like that. They do mention it once in the physiology section, and they don't really elaborate on it. It's just listed there as like, hey, here's something that exists. But what it does or where it's relevant isn't really mentioned. So right here is where they wrote it. Right, so in cases of hypoxemia, where you have decreased oxygen in the alveoli, right, not hypoxia, where you just can't bring in oxygen enough. Hypoxemia is one of the cases where you can have an increased AA gradient and a right to left shunt might occur. So this 2-year-old who has some issue in which lung was it? Acid breath sounds on the right side, right? What is going to happen to this person's lung, this kid's lung? So the answer was right to left shunt. Let's see what they said. This toddler aspirated a foreign body, which you could understand because he was playing with his older brother's toys, which was a significant thing they mentioned. Aspirated a foreign body, which creates a ventilation-perfusion mismatch, right? Perfusion would be working fine. Ventilation would not, right? So he would not be able to breathe in correctly. So that would cause a VQ mismatch. Poorly oxygenated blood is transported from the right side of the heart to the left side of the heart, creating a right to left shunt. And that is what they're talking about when they mention a right to left shunt, right? So right side of the heart to the left side of the heart, creating a right to left shunt. What is this? So poorly oxygenated blood, because now there's a bunch of hemoglobin that's still in his right lung, right? But it's not going to pick up oxygen, and that poorly oxygenated hemoglobin, poorly oxygenated blood is going to come back to the heart, and it's not going to have a lot of oxygen in it, right? So that's going to lead to practically cyanotic things that can possibly occur later on. Failure to improve the oxygen by oxygen therapy in patients with hypoxemia is typical for a shunt, as PaO2 cannot be improved in unventilated lung units. No, it doesn't matter how much oxygen you give this 2-year-old kid, it won't reach that lung because of the blockade by whatever this kid aspirated. Right, so picking a right to left shunt is something that is a weird answer choice for many students because they don't quite understand what's happening here. So this right to left shunt, unlike other answer choices which are usually a physiologic response to something, a right to left shunt is actually a physiologic result to something, not a response. So because there's no air coming into his red blood cells, he's going to have a right to left shunt, which basically just means that there's going to be bad or low oxygen air in his left heart. That's all they're talking about there. Nothing much more than that at all. Right, so very silly little thing, but again, you have to pick the answer choice. The other things in this question would not have been relevant in terms of what the question is asking for. So what would best describe the underlying mechanism of the right lung's impaired ventilation? A right to left shunt, and that would be it. Over here, next question. 85-year-old man with hypertension and type 2 diabetes is brought to the emergency department because of a 2-day history of shortness of breath. He has smoked 1 pack of cigarettes daily for 30 years. Temperature is 98.4 F. Pulse is 100 per minute, which is high. Respirations are also fast, 30 per minute. Blood pressure is slightly high. Pulmonary function testing shows decreased tidal volume and normal lung compliance. What is the most likely underlying etiology of this patient's tachypnea? Okay, so first things first, 85, he's really old, right? Which means his musculoskeletal integrity isn't exactly what it used to be. Brought into the emergency department, shortness of breath. What happened to him? Well, they didn't really quite go into what happened to him, right? Why was he brought into the emergency department? They didn't mention that, right? But at this point, you can assume it could be anything, and you look at all your answer choices and try to see what fits. So they didn't mention any kind of other disease or any kind of skeletal problem that would actually impact his breathing. They only mentioned type 2 diabetes, some level of hypertension, which is evident in him right now, even in the ER. But it's not that bad because remember, when patients come into the hospital and the emergency department, the stress, the tension, the possible pain will all elevate your blood pressure anyway. So I'm not too worried about the 138/75. It's not breaking 150, so it's not going off the charts, and everything else, generally speaking, doesn't seem like is giving away an answer choice here. He smokes a lot, but this isn't a COPD question, and so on and so on. So they just want to know why he has this tachypnea, and the only answer choice that you could actually pick was rib fracture. But you can see how only 24% of people picked it because there was nothing in this question for you to really go with that. Chest wall pain due to a rib fracture limits the range of motion of the chest wall, leading to decrease in tidal volume seen in this patient. And after reading that explanation was when I kind of understood what they were trying to get at here. So not many things can actually decrease tidal volume. Tidal volume doesn't really go down. It's not easy for tidal volume to decrease. Tidal volume is like your entire, how much air you can have in your lungs. And the only time tidal volume really goes down is if your amount of volume in your lungs goes down, or the amount of lung you have decreases for whatever reason. Right, so tidal volume going down was actually the giveaway for rib fracture. Some fractured rib must have caused the lung to go away. To compensate for the decreased tidal volume, this patient has increased his respiratory rate to maintain a normal minute ventilation. Because there is no damage to the lung parenchyma and no underlying pulmonary disease as far as we could tell in the question, he smoked a lot, but they never mentioned anything about COPD or anything like that. His lung compliance is actually normal. In a patient with an inability to increase the respiratory rate due to sedation, minute ventilation would be impaired and could lead to hypoxia. Right, so sedation was another answer choice that would be something you could pick, but he didn't have that problem. Wrong answers were emphysema exacerbation, which would have more lung compliance, tension pneumothorax, where the low compliance would be due to higher intrathoracic pressure from lung compression, and that didn't occur. Diabetic ketoacidosis, which they told you he's diabetic, but this was not a ketoacidosis question, and it would have had a slower respiratory rate. And then, of course, pulmonary edema, which would also have low compliance. right? So the differentials to be able to knock out those other answer choices were a little hard in this one question, just because the main question itself was pretty vague. They didn't give you too much to work with, right? So you don't want to create too much in your head either. Just take what's been given, think of what's most likely, and pick the answer choice that best suits it. These are some notes. So let's take a look at these like extra x-rays that are over here. So this right here in the middle says pulmonary edema. It's a fluid leak into the interstitium and alveoli, presents acutely with dyspnea, cough, fatigue, and crackles on chest auscultation. There will be signs of increased sympathetic tone like sweating and tachycardia. CT would show perihilar pulmonary edema, basilar edema, and curly B lines, which are all, the curly B lines are often very difficult to be able to see. The AP view chest x-ray shows perihilar interstitial opacities that cause a hilar shadow in the shape of a butterfly or bat's wings, enlarged cardiac silhouette, which is being shown with the green shading. So this is all relevant to the x-rays down here. Blunted costophrenic angles with pleural effusion, arched septal curly A lines, and curly B lines. Now those are the weird lines that you can't really see. So on the left we have the amboss image with the shading and the lighting and all of that, so you can actually see what they're trying to point at. On the right is the bare x-ray, and even after looking here to see where the curly A and curly B lines are, which you don't really need to be able to differentiate between A and B as long as you can see the curly lines, it's still hard to see it here. It's not that evident, you know, it's not that clear. Like even these two, it's very hard to see them in this x-ray, you know. So you won't really see something if you're not actually looking for it. That's something that you have to be good at. And if you're thinking the question is about pulmonary edema, then you go ahead and figure out what's causing the pulmonary edema, right? And it could be anything. It could be viral pneumonia. It could be pulmonary edema just because of any other inflammation or sickness. But just make sure that you see something like this, you figure it out, right? Now, the other thing, did they mention? Yeah, blunted costophrenic angles, right? So you see the costophrenic angles should be real nice and smooth. So like, let me get the, so normally, there should be some more x-rays. Normally, the costophrenic angle would just be like this, nothing blunted, very smooth. Right? But you see here, this is like a very intense angle over here, right? And over here, it's not quite blunted on this side, but still, this side is definitely blunted, and that's what they're trying to point at, right? So this area, I'm not really seeing a major problem. It definitely doesn't look normal, but it's not very blunted. But this here, this thing is definitely blunted, very, very blunted, and that is another little thing that can either be an answer choice or whatever, and you have to be able to, you know, pick that correctly. The other thing is his heart is really looking a lot bigger than it should be, right? So this outline is showing you how big it should look, and then the shaded region is how extra his heart is, right? Much bigger than would be expected. Down here is another one that came from Amboss with the shading and then without the overlay. So this is a right upper lobar pneumonia, right? And you can see where the pneumonia is. Even in the blank x-ray, you can see there's something wrong right here. Right? Other than that, this is fine. Everything else is okay here. This is fine. Nothing crazy happening. Right? This lung doesn't have any issues over there. This lung doesn't have any issues over here. Right? So the only problem is that place that's circled right here. Chest x-ray of an elderly woman, PA, and lateral view. Lateral view is given too. Large homogeneous area of increased radio density in the right upper lobe with an air bronchogram, which is highlighted in white. So you can see the bronchogram is highlighted, but without the highlighting, it's almost not visible at all. Okay, so you will not really be able to see this bronchogram that they're highlighting here, because I still can't see it here. Right, but what they're trying to show you is that there's this little gray area that's kind of darker than the rest of it. It's darker because it actually has air in it. It's working. The rest of it is all pneumonia. Right, so very important to be able to practice with actual x-rays so you can catch that. And so a closer look after seeing the overlay that Amboss provided, it was evident that what they're picking at here, which looks like broccoli or something, is just this darker area that has air in it. Okay, that's a little bronchus area. The area of increased radio density is strictly limited to the upper lobe as demonstrated by the dashed lines, right? strictly limited, so it's not crossing over to the other lobes. The lateral view shows distinction of infiltrated lung tissue from the aortic arch, contour marked by the green line. Findings confirm the diagnosis. Right? So again, very straightforward. X-rays are often a giveaway to the answer. You want to make sure that you understand what you're looking at. I'm trying to figure out what this X-ray was for. Oh, I have it right here. Oh, okay, this is the atelectasis for that first question. So you remember this question we just did in the beginning? The first question to start this video with the scoliosis patient, the atelectasis. So this X-ray is his thing, right? So they told you in the question that he had diminished breath sounds on the left side. They told you that he had cardiac silhouette being shifted to the left side, and this is showing you that, right? So you could kind of see he's got a lot of problems in this. Let me just make this a little bigger. It's easier to read. And grab my pencil. Okay, so you can see here though, first things first, as soon as you look at this chest X-ray, it looks extremely weird because you can't really quite see your crostophrenic angles at all, right? This should be visible and it's not. Something is really obstructing stuff here. There's a lot happening here, and clearly this red area is missing a lot, right? And then there's this area which is empty. It's dead empty. So this is showing you the atelectasis, right? Collapsed alveoli, the marked opacification of the left lower lobe, which is the red overlay, and the overall volume of the left lung is reduced, green outline and arrows. Okay, that's how much it's reduced. Right, so loss of lungs on that side. If they give you the chest X-ray, oftentimes the question is supposed to be easier if they give you the chest X-ray, but what can happen on step 1 is they can give you the chest X-ray and not put much into the question, kind of forcing you to just come down to an answer solely based off the chest X-ray. And that can be pretty challenging if you're not very adept at looking at multiple chest X-rays. So one of the best things about having this first aid that I've annotated is this collection of chest X-rays with explanations put into the book right where you're about to see the stuff, right, either before or after. So we looked at a couple of pneumonia things, and now we're going to see about pneumonia. I wish I had AMBOSS codes. I don't really have AMBOSS codes right now, but I have kind of applied to be what they call an ambassador, right? An ambassador of AMBOSS. And I was working with AMBOSS pretty closely, like almost 2 months ago, but then the whole coronavirus stuff started kicking in, so that's on hold right now. But maybe eventually, if I do get anything, I'll make sure I post about it and talk about it in the video. And then for the other question over here, what to do as a Q-bank before UWorld, I don't think there is anything that you should look into before UWorld. In my video where I talk about how to study effectively, I made it a couple weeks ago. I tell you guys that you should do UWorld questions every day when you're studying. It should be relevant to the topic you're studying. So like, for example, if today you are studying respiratory, then while you're doing it, you should be studying respiratory UWorld questions, going through them. And I say studying questions, not doing the questions, because you should be coming back to first aid after almost every single question, you know, just to revise what's happening. Because the more times you look at first aid, the better you get at it. So here we are with pneumonia. Now, we've talked about pneumonia a lot when we did microbiology, right? And in my video that I talked about the study routine, I also mentioned when to go back and revise things. So evidently and very clearly, this would be a great time to go back to microbiology systems and microbiology as a whole chapter itself and revise these bugs, right? How they present, what's special about them, why they are the way they are, and what their characteristics are. You got to know the bugs' characteristics, because now, lately, not even lately, for quite a while now, UWorld, AMBOSS, and of course Step 1 have shifted away from just naming a bacteria or naming any microbe to actually talking about the characteristics instead. So for example, instead of putting Legionella as an answer choice, they might say some microbe that stains with silver stain, and you have to remember that, you know. So it's a very annoying thing. So we have lobar pneumonia, bronchopneumonia, atypical pneumonia, and then cryptogenic organizing pneumonia. Now this one's a little weird, so we'll come back to this after really talking more about these in depth. Lobar pneumonia is extremely common. Right? This is due to S. pneumoniae most frequently, but can also be Legionella and Klebsiella. Now, for each one of these, you should be able to mention characteristics that help you pick them, right? S. pneumoniae had the mop stains, and if you did Sketchy Micro, you remember the image was about S. pneumoniae versus strep viridans, and there was a bunch of things about optogen sensitivity, whether or not it was encapsulated, and then of course the vaccinations. And S. pneumoniae was encapsulated, it was a knight, but his chin was visible, so it was optogen sensitive, right? And that's a very important thing that can be an answer choice instead of just putting S. pneumoniae as an answer choice. Legionella was also really special. That was that silver stained ship image where it's a very interesting kind of practically atypical pneumonia as well, because it also presents with diarrhea and CNS issues, and then it was also possible that Legionella could cause Pontiac fever. And Klebsiella is the giveaway answer choice for any time you have a patient who might have gone through aspiration pneumonia, right? Either because they were drunk, right, alcoholics, or they have weakened muscles in their throat, maybe they have seizures, whatever it might be. So what do you see in lobar pneumonia? You're going to note intra-alveolar exudates leading to consolidation, may involve the entire lobe or the whole lung. And they show you a consolidation right here. Right, so here we have a consolidation of the right lower lobe. Right, earlier we looked at this one as a consolidation of the right upper lobe. Right, and which lobe things are going to go into really depends on, like we saw earlier in one of the videos not too long ago, where we talked about the aspiration stuff, right? If you aspire a nut or a peanut, if you're standing, if you're laying, and the fact that one of your bronchi is more linear, so things tend to go to the right more. Then you have bronchopneumonia, and this is pretty much S. pneumoniae, S. aureus, H. influenzae, Klebsiella again. This is an acute inflammatory thing. From bronchioles into the adjacent alveoli, there's going to be a very patchy distribution involving more than one lobe. Right? It's a very clear difference between lobar pneumonia, which is just one lobe, and bronchopneumonia, which is affecting the bronchi, so it's going to more than one lobe. Okay, and they gave not exactly a chest x-ray, but they gave more of like the histological slide of showing you the inflammatory infiltrates here. And then this, an actual gross specimen showing you how multiple parts of the lung and possibly even the whole lung are affected. Atypical pneumonia is really just only atypical if the pneumonia presents in a way that normal pneumonia won't present. So how do I describe atypical pneumonia very easily? Let me see what they say. So they're just talking about the different types. Usually any pneumonia where the patient doesn't look like they have pneumonia, that's an atypical pneumonia. Any pneumonia which is presenting with symptoms other than just respiratory problems is an atypical pneumonia. For example, like we said about Legionella. Legionella can cause pneumonia, but it also has extra pulmonary symptoms, right? Things that are unrelated to the lungs. So in Legionella pneumonia, patients can have diarrhea, which is not related to the lungs. Patients can have CNS issues, not related to the lungs. That is an atypical pneumonia. When you look at Mycoplasma pneumoniae, this one, the sketchy micro image of this would remind you that they have cold agglutinins, right? And cold agglutinins is not really related to the lungs. So again, atypical pneumonia. And the patient would have walking pneumonia because the patient's going to come in looking okay, and then you do the chest x-ray and they look like they should be bedridden. The chest x-ray is like completely fucked. So that's a very important thing to watch out for. Chlamydophila pneumoniae is different because chlamydia are usually intracellular, right? And you can't really find the bugs. So both Chlamydophila pneumoniae and Chlamydophila psittaci, which was the one related to parrots and stuff, completely difficult to find. And then all the viral ones, right? So interstitial, atypical pneumonia, all the viral ones, right? So respiratory syncytial virus, cytomegalovirus, influenza, adenovirus, these are atypical pneumonia. These are pneumonia that are going to present with other symptoms because these viruses cause multiple things, right? And the biggest issue right now in our time with respiratory viral issues is coronavirus. This is extremely high yield right now, right? Coronavirus is very evidently an atypical pneumonia in a sense because it completely fucks up the entire lung, but there are also many findings of extra pulmonary symptoms. Patients presenting with a cytokine storm, patients presenting with some level of hemorrhage in the toes, right? necrosis of the toes, all kinds of weird symptoms are popping up, and we're learning more about coronavirus every single day. So, it's going to be a high yield topic. If not right now, then definitely by next year on step 1, it's going to be a major thing. Every step 1 is going to talk about coronavirus. The last thing here, cryptogenic organizing pneumonia, COP. It's a very weird, pretty rare thing, but it is a real thing and it can definitely be on your step 1, so it's totally worth knowing. The etiology is unknown, which kind of helps us, and it harms us. It helps us because no one's going to ask us for the etiology, but it harms us because questions won't give you an etiology. There's no reason to. And if a question does give you an etiology, it could still be relevant to this. Secondary organizing pneumonia caused by chronic inflammatory diseases like rheumatoid arthritis or medication side effects like amiodarone, which really has a bunch of side effects. There will be no sputum and blood cultures and no response to antibiotics because it's not relevant to any infection. Okay, so that's going to be something you're going to watch out for. So since it's not due to infection, the patient will have no fever, right? That's another really helpful topic there. Formerly known as bronchiolitis obliterans organizing pneumonia, but they renamed it because bronchiolitis obliterans was more of an autoimmune thing relevant to lung transplant rejection. Non-infectious pneumonia characterized by inflammation of the bronchioles and surrounding structure. That's a secondary organizing pneumonia. Very weird thing, very rare thing. I've actually never seen a question on it, but it's pretty easy to know. And it's pretty easy to pick as an answer choice, or even anything else here as an answer choice, because it wouldn't have anything to do with one of these things. There would be no infection, no fever, no consolidation, none of that. It's just bronchiolitis, right? So here is just a simple explanation of natural history of lobar pneumonia. So this is kind of like the progression of a lobar pneumonia, which is similar to the progression of an MI or any other topic that we've looked at before. They break it down into congestion, red hepatization, gray hepatization, and resolution. There's a hepatization. So this is a very key word here because what happens is that the lung kind of starts looking more like the liver, and that's why they call it hepatization. So in the first 2 days, you're going to have red-purple partial consolidation of the parenchyma, and you're going to see some exudate with mostly bacteria. On the bottom right here, we have a U-world image that's depicting those things, and then we'll look into this question that's relevant for this topic right now. Red hepatization is number 2, and you can see at red hepatization, it looks like the liver now. This is exactly what the liver would look like if it was drawn in this cartoon as well. So it's got a red-brown consolidation now. You're going to have exudates with fibrin. That's the main thing. That's the main takeaway. Forget the bacteria, RBCs, and white blood cells. The fibrin is the giveaway for the red hepatization. And they point that out in the U-world image a little more. Right? So they mention the fibrinous exudate right here. Right? Fibrinous exudate. Gray hepatization occurs by the end of the week. You're going to have a uniformly gray exudate full of lysed red blood cells, right? So now the special thing here are the lysed red blood cells, right? You're going to have a decrease in red blood cells that are lysed, and you can see it's all going to turn gray, right? You still have the fibrin, you still have the white blood cells. The white blood cells are not going anywhere, but it's the lysing of the red blood cells that are going to be the significant little thing to help pick gray hepatization as an answer choice. The last thing after that 1 week of natural history of lobar pneumonia, you're going to have resolution, where eventually enzymes are going to reach and digest components of the exudate. Okay, but you still have some inflammation. You can see there's still fluid in here in this alveoli, which is not normal. You still have your fibrinous exudate being liquefied and expectorated, so you're coughing it out. And macrophages are replacing the neutrophils now. Right, so more macrophage, lesser neutrophil. Initially, it was all neutrophil in here. This question here is relevant to this natural history of lobar pneumonia. So it says a 64-year-old man is evaluated for worsening cough and shortness of breath. The patient has a history of hypertension, type 2 diabetes, smokes a pack of cigarettes daily, and drinks alcohol occasionally. So 64 is pretty old. Worsening cough, definitely a problematic issue. Smokes and drinks occasionally, so that's relevant. But the most relevant thing here, temperature is high, 101. Blood pressure is high. Pulse is 92, not the biggest deal, but the temperature, he has a fever, right? Lung auscultation reveals abnormal breath sounds, and a chest x-ray is given, where you can see a right lower lobe infiltrate. What is the most likely cause of the observed pulmonary findings in this patient? And then you get a bunch of different answer choices describing various mechanisms, and this was actually not so bad, but people were confused. Answer choices were everywhere for the things people chose. Check it out. Correct answer was leakage of protein-rich fluid in the alveolar air spaces. 39% of people got it right. Now, 42% of people were confused between these two answer choices. 21 chose elevated pulmonary capillary hydrostatic pressure, and 21% chose mucus gland hyperplasia and inflammation in the large airways. So, without solid understanding of what's happening to this patient, all three of those answer choices are actually very likely answer choices, and you might not even right now know how to cancel out one over the other. So let's take a look. His symptoms and chest x-ray indicate lobar pneumonia, likely due to community-acquired pneumonia like strep pneumoniae. Lobar pneumonia is characterized by a stepwise inflammatory response as follows. And then this URL question further delved into what the book is talking about, right? So congestion with the neutrophils responding to the bacterial components, releasing of cytokines, easily migrating into the area, more capillary permeability for the red blood cells to come, resulting in the affected lobe becoming heavy and red. Then you have red hybridization. The proteinaceous fluid transforms into fibrin strands, resulting in a confluent exudate of fibrin, neutrophils, and red blood cells. Gray hybridization is where you finally have the lysing of the red blood cells, right? Neutrophils begin to be replaced by macrophages that begin the repair process, which then leads to resolution. In comparison, bronchopneumonia is an infection of the terminal bronchioles and results in patchy consolidation of a number of lobes. Interstitial pneumonia is an infection of the lung with minimal or no alveolar infiltrate, and atypical pneumonia like mycoplasma or chlamydia. Right, so the elevated pulmonary capillary hydrostatic pressure answer choice is characteristic of a cardiogenic pulmonary edema. We didn't have that. Right? Why would you not pick pulmonary capillary hydrostatic pressure? Because this pulmonary capillary hydrostatic pressure stuff is related to cardiogenic pulmonary edema, and those 21% of students didn't have that solid understanding of that. They wouldn't have picked that if they remembered that that answer choice is related to cardiogenic pulmonary edema. Our patient has non-cardiogenic pulmonary edema. His pulmonary edema is not because his heart isn't working and blood is backing up from the left atrium into the lungs. That's not what's happening here. When your left atrium isn't working or left ventricle isn't working and blood starts backing up into the lungs, that causes pulmonary edema, and you're going to have an elevated pulmonary capillary hydrostatic pressure. The other answer choice, the mucus gland hyperplasia and inflammation in the lung airways, that choice characterizes chronic bronchitis with goblet cell metaplasia, and lobar infiltrate is uncommon. They mentioned this. This is also called the Reid REID index, right? The Reid index, and that was related to chronic bronchitis, COPD. Right? So this answer choice, mucus gland hyperplasia, where the Reid index increases, that is COPD. That's not what this question was about. This guy has a high fever. He's going to have a leakage of protein-rich fluid into the alveolar spaces, and that's what's happening here, right here. You see how this is all full of fluid, and it's very proteinaceous because of the fibrin, and then of course there's red blood cells and white blood cells in there. All right. So not a bad question, but of course very worthwhile question, because clearly 42% of people were lost on this question because they couldn't see the differentials between these three different answer choices. So make sure you know that. Leakage of protein-rich fluid, that's the pneumonia. 21% choosing pulmonary capillary hydrostatic pressure, that is cardiogenic edema due to heart failure. And then mucus gland hyperplasia and inflammation, that's COPD, completely unrelated, well, not unrelated, completely different topics, right? Three completely different topics. So now the next page has a bunch more images for each of the different kinds of pneumonias that we would be looking at, as well as some histology. Let's take a look at these first two questions, and then we'll look at the rest of the images. So first one here, AMBOSS, a 32-year-old man comes to the physician because of low-grade fever, dry cough, and shortness of breath. So the fever is giveaway for infection. His symptoms began 6 days ago while he was on vacation in Thailand, where he went to an urgent care clinic and was started on cefuroxime. Temperature is pretty high still. Physical exam shows decreased breath sounds at bilateral lung bases. X-ray of the chest shows diffuse patchy infiltrates. Sputum analysis shows numerous neutrophils, but no organisms, right? So the moment you don't see any organisms, you start thinking this is most likely some kind of atypical pneumonia. GM sustain shows epithelial cells with cytoplasmic inclusion bodies. This patient's condition did not improve after the initial treatment because of which of the following properties are the most likely causal pathogen. So clearly there's some kind of infection, but it didn't stain correctly, which means it probably doesn't have the peptoglycan cell wall. And when you see that in the answer choices, you just pick that and you're done. This patient had Chlamydophila pneumoniae, which is an obligate intracellular bacterium, only visible as intracellular inclusion bodies. Chlamydia in general had reticulate bodies and other kinds of bodies like that, which were relevant to their function. And this is the only answer choice you could pick. Other answer choices would explain other mechanisms for different medications, and the question is doing a good job trying to intimidate you into thinking, oh shit, what was cefuroxime's mechanism of action, blah blah blah. You don't have to worry about any of that. The guy is a young man with some pneumonia infection. He isn't bedridden, which is pretty crazy, right? He's okay. He's not hospitalized, but he obviously has pneumonia. That is an atypical pneumonia, right? And that pneumonia is not being stained correctly. Can't see it. And then it was intracellular, which is all giveaway that it must be chlamydia. Chlamydophila pneumoniae. Like other chlamydia species, this lacks peptidoglycan in its cell wall and is therefore resistant to beta-lactam antibiotics, which act by inhibiting peptidoglycan cross-linking. First-line treatment for this would be a macrolide antibiotic, which inhibits bacterial protein synthesis. Right? Any antibiotic that doesn't really depend on having a cell wall. The next one, 37-year-old man comes to the physician because of fever, night sweats, malaise, dyspnea, and a productive cough with bloody sputum for 4 days. So very evidently pneumonia, right? Could be. It's not going to be atypical pneumonia at this time because he's coming in a really bad state. He doesn't look like he's okay. He's having night sweats and bloody sputum. He was diagnosed with HIV 15 years ago, so he's a long-term HIV patient and not compliant with his medication. So most likely his CD4 count is extremely low, right? He's not taking care of himself. Physical exam shows diminished red cells over the left lung. X-ray of the chest shows ill-defined lesions in the upper lobe of the left lung. CT-guided biopsy is performed and a photomicrograph of the biopsy specimen stained with mucicarmine is shown. Which of the following is the most likely causal organism? So even without looking at the actual image, the fact that they said it's stained with mucicarmine is a giveaway for Cryptococcus. You don't even need to worry about the image anymore. Right? Cryptococcus neoformans is a pathogenic fungus that has a thick polysaccharide capsule and therefore stains bright red with mucicarmine. The fungus is primarily transmitted via soil or pigeon droppings and initially infects the respiratory tract. Infection is typically asymptomatic, but Cryptococcus may occur especially in immunodeficient individuals, like our patient here. Cryptococcosis usually manifests as isolated pneumonia, as seen in this patient, right? No other symptoms, no extra respiratory symptoms, just respiratory, nothing in the brain, nothing in the diarrhea area, none of that stuff. But in cryptococcal disseminated infection, you could have meningoencephalitis, especially in an HIV patient. But again, when you're dealing with HIV patients, you have to understand that if they came in with one infection, it's most likely possible they also have other infections. Right? So not just one bug might be causing all the different symptoms they have. So what are some of these images we're looking at right here? So this one here is Cryptococcus, a lung sample under mucicarmine. This is exactly what it would look like. And if you can't remember mucicarmine and what it does, looking at that picture might actually just throw you off and you might not have any idea what the heck you're looking at. But even then, you know for sure you're not looking at a bacteria. This is not a bacteria, it's circular. And you look at all your answer choices, you pick the one that you can best recall having anything to do with a circle. This one here is showing you Coccidioides immitis, the thick-walled eosinophilic spherule filled with endospores and surrounded by a dense inflammatory infiltrate, right? All the little cells inside that bigger body. This fungus is usually seen with KOH staining. And then this is another notorious one, this blue image. It's Pneumocystis jirovecii, right? A very common thing for HIV and AIDS patients, and that's stained with methenamine, right? Pneumocystis is also often described to be cusp-shaped. Looks like a sickled red blood cell, but it's not going to be red, of course. So depending on what, this level of staining in this image isn't exactly the best. But if they tell you methenamine, then you can easily think of Pneumocystis jirovecii, especially for an immunocompromised patient, and just move on with your day. These chest x-rays here, so let's take a look. These are all different lobar pneumonias. Over here you have the entire left lung with pneumonia, right? This one is showing you right middle lobe lobar pneumonia, right? And then this again is lobar pneumonia in the right upper lobe. Okay, different places presenting differently. Right? Here, both of the above two, these two, are bronchopneumonia. Why is it bronchopneumonia? Because you have patchy distribution involving more than one lobe of the right lung. Right? Bronchopneumonia. Same thing this one too. This is also sort of, this isn't just lobar. This would also be kind of bronchopneumonia because it's going onto the whole thing. The only thing is bronchopneumonia is usually more of an answer choice if it's actually affecting both sides too. So difficult diagnosis to make between the two, but definitely doable. Below is an atypical interstitial pneumonia with increased lung markings due to diffuse interstitial infiltrates. Right? Crazy. The whole thing is just full of like an electric spark. This is a visualization showing you the differences. So you have your bronchopneumonia, which is affecting multiple parts, right? And it's only occurring in this one lung here. This down here is a lobar pneumonia, which is picking one lobe, and that's it. Okay? And then here is interstitial pneumonia, which is everywhere. Interstitial, the whole thing. Atypical. The last topic left for respiratory pathology is this huge oncological problem of lung cancer. Right? Lung cancer is an extremely big issue. This is the stuff I work with right now with my clinical research team. We do head, neck, and thoracic cancers, but the most common thing we work with are lung cancer patients. And a lot of the treatments are based off of one of the medications that are fairly new in first aid. Things like pembrolizumab, the PD-L1 inhibitors, right? PD-L1 antagonists. You want to make sure you understand how those work because those are pretty new upcoming research medications. All over clinical trials are happening for it because it's a medication that can work on many different mechanisms and many different kinds of cancers. So make sure you understand the whole PD ligand and how all of that works. It's in the book. They talk about it under the pathology neoplasia chapter. Cancer evasion by the immune system, right? Or immune evasion by the cancer is a very big topic. And if you could somehow come up with a medication that stops the cancer from evading your immune system, then your own immune system will take care of the lung cancer or any cancer, and you'll be curing cancer, right? So we're getting there. We're definitely getting there. If things go well, eventually all of this is going to be things we'll look back at and imagine, can't believe people used to die of cancer. Hopefully there will be a day where people will say that it's unbelievable that people used to die of cancer. Because today it's still a very big reality. So in the next video, we'll continue on into lung cancer, do a couple more questions, wrap stuff up, lung abscess, pancreas tumor, and SVC syndrome, and then we'll be done. Respiratory pharmacology is a very tiny chapter, very tiny section that's like half a video long. So I'll try to wrap this up as soon as I can, then we'll finally be done with the full First Aid Mastery playlist. Thank you very much for joining. I'll see you guys again pretty soon.